Okay, it's 7 o'clock. Good evening from New York City. My name is Bob Akivi. I'll be your host tonight. Tonight we have an excellent panel and excellent cases. We are very excited to have you all. Our guests tonight are Dr. Megan Turner from West Virginia University, Dr. Ken Bird from Medical College of Georgia, University of Augusta, and Dr. Matt Geldzeiler from Oregon Health Science University. Our discussants are Dr. Ehab Hanna from MD Anderson Cancer Center, Dr. Nancy Lee from Memorial Sloan Kettering Cancer Center, and Dr. Catherine Price from Mayo Clinic, Minnesota. Very excited to have you all. Without any further ado, we're just going to start. Dr. Turner is going to start the case. Megan?
All right, I will take, can you all see my slides?
Yeah, if you just put it on the presentation mode. Yeah.
Let me go from start. Okay, so this, our first case is a 38-year-old female who presented to my clinic back in 2018. She was referred to me by one of our local ENTs, who she was actually the secretary in their office, and she had been having about 2 months history of right-sided facial pain. And her local ENT performed a CT sinus, which showed a mass in the right maxillary sinus. She was referred up to us with no additional workup done. When I met her, I did a physical exam, all the typical things, asked her a little bit about herself. She was a never smoker, rare alcohol use. She was a single mother with 3 children. All I think very important things to consider as you have somebody going through treatment. On physical exam, she had hypoesthesia in V2 with radiating pain in that distribution and also going along her palate. When I did a physical exam with pinprick and light touch using Q-tips, she had also palatal numbness on the right side. And when you examined her nasal cavity and oral cavity, there was no notable mass in the nasal floor. And that was even true on palpation. Things were nice and smooth. Looking into her oral cavity, she had no loose teeth, no lesions of the gums, no asymmetry of the alveolus that you could really notice. The only thing that was abnormal is when you looked in the very posterior aspect of the sublabial or canine fossa, she had very prominent vessels back posteriorly, going up into the pterygoid area. And then on endoscopy, there was notably no mass other than some fullness in the inferior meatus. At this point, I didn't feel like I could get a biopsy or further workup in the office. We had reliable imaging, but I got an MRI.
So what patient came to you with a CT already, correct?
She did, yes. So I didn't have to.
Do you have an image?
I had enough to know I had a mass that I could not see. The next step for me was biopsy.
Yeah, okay. So Dr. Hanna, let me ask you first, how much do you insist on getting a biopsy right up front when you don't see a tumor?
Well, I mean, the clinical history here is very concerning for a malignant process given the neurologic deficit. Of the sites within the head and neck, the palate is the most common site for a minor salivary gland malignancy, and adenoid cystic being the most common within that group. So to me, I mean, this patient has a permeative process in her hard palate, and adenoid cystic in the palate is commonly not associated with a mass intraorally or intranasally. So imaging prior to biopsy is indicated in these cases just to confirm the presence of a permeative process And if I were to start with an imaging modality with this clinical picture, I would definitely start with an MRI first, given the proclivity for neural symptoms and signs here. And MRI is much better assessing a perineural process than a CT would.
Okay. Very good. Megan?
Recording.
Megan, you're muted. Just unmute yourself, please. Okay.
Yes, so I wanted to get her further imaging and a biopsy.
Yeah.
Her insurance company actually gave me trouble with getting additional imaging because they said, well, you have imaging. So I set her up for a biopsy. We did a biopsy in the operating room. Let's see if I can get this to advance. There we go. And so I took her to the OR and got into the inferior meatus, lifted up the inferior turbinate, did a very simple endoscopic medial maxillectomy to expose the mass, and biopsied her. And we stopped there. That gave me an additional diagnosis. It came back as adenoid cystic carcinoma, which I was concerned about given her nerve distribution pain, and the appearance of the mass. It was mucosal, it was not erosive. And so on her, and I apologize for not having her CT scan because that was on outside imaging. So it was difficult for me to get a picture of it. But this is her scan. There's a video, and I have this still of the mass, which you can kind of see that it's involving the pterygoid here. There's all this soft tissue density, and this is not just inflammation from her biopsy. There's something in the bone, and on her CT scan, you could see this erosion and expansion of the lesser and greater palatine canals, the pterygoid bone just at the base and body, and then you could see fullness in her pterygopalatine space.
So Megan, we all rely very heavily on our radiology colleagues. For this one, did you see any intracranial disease?
So no, there was no intracranial disease. It was only the pterygopalatine fossa. And we discussed that pretty heavily at Tumor Board, and we discussed what V2 looked like in Meckel's cave, and all of that was normal. It was limited to the floor of the sinus, the descending palatine nerves, and the pterygopalatine space.
Perfect. So let's get all of it. Now, did they tell you if it's a solid, or did they give you any more information on the biopsy?
Oh, they did. It was the tubular variant.
Okay, so Dr. Hanna, patient, pretty extensive disease here. What would you recommend? And then I'm going to ask Dr. Lee and Dr. Price.
I am still concerned about the extent of perineural spread, and where there is no gross disease in Meckel's cave. I think, and I couldn't see from this MRI how far back. I mean, she's numb in V2. So I want to see a high resolution thin cut imaging of how far backwards it goes around V2. The other nerve that I worry about in this disease is the Vidian canal. So both V2 and Vidian needs to be imaged with thin slices and high resolution. And I trust Megan looked at that, and assuming that there is no perineural disease beyond the description that she mentioned. We have a locally advanced adenoid cystic cancer in a woman who's 38 years old. I would want to type her tumor as well to some of the more recent targets for adenoid cystic cancer.
Would you routinely send for Foundation One or your own homemade or the in-house genetic panels nowadays?
On a case-by-case basis. I mean, the systemic workup has not been completed. She would need some sort of metastatic workup. And people argue a lot about what is the optimal modality PET-CT comes to mind as a very efficient way to look for distant disease. The problem with PET-CT and adenoid cystic cancer in particular is that it is not necessarily avid even with known metastatic disease in a substantial number of patients because of the low metabolic rate and slow rate of growth of adenoid cystic cancer. So a negative PET doesn't necessarily make me feel comfortable. We still think a high resolution chest CT is a good way to look at the lungs. Typically, however, if there is bone metastases, they will light up on the PET with adenoid cystic cancer.
So Dr. Price, at Mayo Clinic, would you guys routinely send for Foundation 1 or other for when you have an adenoid cystic, especially advanced ones?
So we will do it routinely for all of our metastatic patients in various capacities. I'd say we don't necessarily do it right off the bat, for a process that's clearly locally advanced where we're looking at, multimodality sort of definitive treatment. Sometimes we do, but since that doesn't typically kind of impact the initial treatment for a patient you're treating with cure, we don't always do that, but we do routinely for anybody with metastatic disease. We don't always act on it right at that moment, but to, have plan for future therapy as needed.
Okay. So it looks like, Megan, you have some surprises for us here.
Well, so she had metastatic disease on presentation, and the patient asked me, I think initially, could we just do this all at once? And I said, well, I think we really need to know the extent of your disease before we make these decisions. And so that's the reason I stopped with a medial maxillectomy that day. And we got this additional imaging. And, you can see here on the right, she had a lung met at presentation. And so I really felt like we had to have a discussion about her prognosis and all that a curative surgery would entail. And you can see this thing is limited just to the floor. The infraorbital canal is free on this. I'm not sure if I have a video. It is based in the bone here. You can see there's some erosion where there exists none here. So it was filling the whole alveolus. That's not just the maxillary sinus over here.
Oh, okay. I apologize if sometimes I have to push because we only have 20 minutes for each case, and out of respect.
Oh, absolutely.
So oligometastatic disease? Just
we operated with just the oligometastatic disease, one lung met.
Give me 1 second before you say what you did. Dr. Hanna,
Sure.
What would you do? And then we're going to ask others.
Well, I think you asked the question about Foundation 1. One of the things locally that we do for patients with metastatic disease is we test them for the Notch mutation, Notch1 mutation. It is much more common in the solid variety rather than the tubular variety. We have an ongoing clinical trial for patients with metastatic disease, and actually another one with patients with just local regionally advanced disease where surgery is not likely to achieve negative margins, where we give them preoperative Notch inhibitors. So that's just something that I throw out there because it's one of the newest potential targets for adenoid cystic carcinoma. Having said that, there is plenty of evidence to suggest that local regional therapy, aggressive local regional therapy is still indicated in patients with oligometastatic disease defined as less than 3 sites throughout the body. And single lung metastasis definitely corresponds to that. And the data suggests that if you do aggressive local therapy, and then for a single lung met, perhaps even a single metastatectomy, that you do impact the outcome of this patient compared to if you did not, assuming that they have distant disease and then you back off aggressive local therapy.
So you would offer appropriate local. So Dr. Lee, the patient comes to you and says, some famous surgeons are telling me that they want to take half of my face off and I have metastatic disease. What would you say?
Yeah, no, I agree with everything that's said. Well, first, agree, we don't routinely upfront do impact testing. For distant metastases, we may obtain it, and then later on, Allen Ho, if the patient recur or have progressive distant disease, we will have some targeted therapy trial to place the patient on. She's 38 years old. She has aggressive local regional disease. I agree with Dr. Hannah. We should do surgery and then followed by postoperative radiation therapy. She has a single site solitary met in the lung. It's easy addressed by either surgery, or surgeons sometimes will operate, or we can SBRT that region. It's very easy to do. But to me, we need to really target well, control the disease local regionally from a radiation oncology point. Not only do you treat the palate, the maxilla, it's critical that you go all the way to the Meckel's cave, because that's how adenocystic behavior all the way to the Meckel's cave. I think it's a mistake. Some radiation oncologists will not go all the way to the top for fear of brain dose, but I've seen failures where they just fail superiorly to the target. So I think that's critical. I mean, your dosing could be different. You don't have to go to a high dose in the Meckel's cave area versus the postoperative bed area.
So before we ask Dr. Turner what she decided to do, just quick question for you and Dr. Price. Yes, no. Any role for preoperative radiation or preoperative targeted treatment or chemo? Dr. Lee first.
Yeah, no, I don't think that's the standard. If you have a trial, I'm interested to hear EHAB, what they do at MD Anderson. We don't have a trial given in the preoperative setting. When you look at squamous cell carcinoma, we've done this before, right? Pre-op versus post-op, and post-op is always better in terms of local control. So we kind of borrowed from squamous experience to all other sites. We always operate first, clear gross disease, then add the adjuvant therapy.
Perfect. Dr. Price, any role for neoadjuvant targeted treatment or chemotherapy?
Outside of a clinical trial, no. I mean, I think for adenoid cystic, where patients can live for years with this disease, even in the face of metastatic disease, having, control of the disease in the head and neck is critical for a morbidity, from a morbidity and quality of life standpoint. But no, I mean, adenoid cystic carcinoma is probably one of our most difficult tumors to treat. We don't have any reliable systemic therapy where we, can say, there's a really high chance that this is going to work. So no, I would not do anything up front. Perfect.
So Megan, tell us what you decided.
So she had a maxillectomy. It was an infrastructure maxillectomy. It included removal and total exoneration of the pterygopalatine space, and removal of the pterygoid body and drilling that, and biopsy of the vidian at its depth. And that was negative. That was the only nerve that appeared to be locally at risk. She was obturated initially. We wanted to see how she did, how she healed, and go through all of her adjuvant radiation well before considering any reconstruction. She and I talked about how, based on studies from Memorial Sloan Kettering, you can live for 10 years with lung metastases. This is a different disease. That was important to her to be treated aggressively because of her children. She had a lung wedge resection robotically in October after she recovered. And she was actually referred to MD Anderson for their clinical trial. She, I believe, had treatment with Dr. Ferraroto. Does that sound correct? That is correct, I think. And recently underwent her reconstructive surgery. Unfortunately, she's had progression of her lung metastases, but she's asymptomatic and doing well. This was her post-surgical cavity defect. And the worst thing for her was really her trismus. But on the whole, she's functioning and doing well with her children.
Quick question. Did she receive post-operative radiation or chemo radiation?
She did, and she did get treated in Meckel's cave. Regardless, I think we were being very careful because of all the pterygopalatine space involvement, and there were intense discussions about how high into Meckel's cave to go and not having local regional failure the patients who have local regional failure at the skull base will only live 2 or 3 years. And so now we're 3 years out and she's still without disease.
So a couple of quick, excellent case. Really, thank you for sharing this. This is, as always, challenging. A couple of quick questions for the group, and then we're going to round up. Dr. Lee, in this case, when you do post-op, would you recommend chemo RT or RT alone? And if you recommend chemo RT, we'll ask Dr. Price what would be the preference. We are still waiting for the trial.
Yeah, so RTOG 1008 attempts to answer the question, right? Surgery followed radiation plus or minus weekly cisplatin. Off trial, I can tell you, we'll look at the pathologic finding. If let's say there were multiple adverse features, we have a very frank discussion of the risk benefit in lieu of no randomized data yet. I think we are heading toward chemo radiation if there's a lot of adverse features, such as multiple lymph nodes, positive margin, ECE or in this case, not ECE, but LVI, PNI extensive. But it's not our routine to give post-op RT off trial.
Okay. Catherine, what would you recommend for adjuvant when you do concurrent? Do you go with cisplatin or
Yeah,
are
so
we doing immunotherapy yet for these or not yet?
No, single agent response rate of immunotherapy with salivary cancer is quite low. If we do it, we would do weekly cisplatin, 40 milligrams per meter squared. And as Dr. Lee said, this is sort of a case-by-case basis. If it's a patient that has adverse features or high-grade histology, and young patients too, we'll just kind of, talk about the lack of clear data, talk about the, risks and benefits, and kind of have a discussion with them. And to be honest, most people, will fall on one side of the fence. And I think patient preference is really important in this decision because we don't really know exactly who benefits. So, some patients will say, I don't want to have chemotherapy if you can't tell me there's good data that it's going to work and I want to avoid side effects. And others will say, I want to do anything, even if there's a small chance it might help me in some capacity and I'm less worried about side effects. So usually the patients will kind of really help in this decision.
Great. Fantastic, Kate. Thank you so much. We got to move on. This case, we can spend the entire hour really on just
really important question.
Yeah.
Reconstruction, obturator or free flap? That's always my question.
Free flap all the way. I'm very proud of Megan that offered patients free flap. The quality of life is so much better than to this date, and correct me if I'm wrong, if there's been any evidence that by doing obturator, we will change if this tumor is going to come back after good surgery, really the options are limited. And not having an operator for a young woman being able to phonate and eat well, I think that means a lot. So that's my opinion and I stand by it. Okay, let's go. Matt, you want to go next?
Sure. Hey, everybody. Thanks for having me.
Dr. Geldslider from OHSU.
I'm going to share my screen. All right. So hello, everyone. My name is Matt Geldslider. I work at OHSU in Portland, Oregon. This case is going to be controversial. So yeah.
That's why you're here. Let's bring it on.
So I have disclosures. I'm a consultant for Stryker and Intersect ENT. None of that is relevant to this patient. I have a case of a 64-year-old woman who presented with a left sinonasal mass. She had 4 months of epistaxis and epiphyseal, some nasal obstruction. She had some diplopia and decreased vision and significant orbital pain, no neck masses and good performance status. She presented with some mild proptosis and restriction of her extraocular motions, some paresthesia in V1 and no neck masses. And on endoscopy, there was a large mass kind of coming out of her nose. So here's a CT scan. Let's just try to go through this slowly. You can see the mass on the left side of her nose. We're going to focus on the bone here. There's obviously erosion of the lamina. This tumor is going into her orbit adjacent to her medial rectus. It erodes the skull base and is eroding the crista there, extending onto the right side of her nose and continuing to have a significant erosion of the skull base and into the orbit, extending back posteriorly. Here's an MR.
Tumor, you don't see anything really.
Here's her MR. The non-fat saturated images looked better when I was putting this together. So that's what's included here. And just the point here is you can see the significant erosion into the orbit, pushing against the medial rectus, and also extending intracranially up against the dura. If we had the T2s to look at, there was no obvious brain parenchymal invasion. There was no T2 signal change, and there was a preservation of the CSF space beneath. And on the axials, you just can see more of the same. We'll just let that one run.
Matt, did the patient come to you with a biopsy, or you did the biopsy?
No, I biopsied it in clinic right then. Whoops. Sorry about that, guys. Whoop. So I biopsied it in the office, and it came back as a malignant melanoma. We did some additional testing at the time, given the aggression of the disease. So there was negative. We have something called Gene Trails, which is our in-house genetic testing. We also have a specific melanoma mutation panel, which is obviously designed for cutaneous, but we use it here. And the patient was negative for everything listed there. So PD-L1, c-KIT, NRAS, and BRAF. We clearly did a PET scan, and that was negative for any cervical adenopathy or any distant metastatic disease. So we staged this woman as a T4B N0 stage 4B mucosal melanoma.
Okay.
The paradise.
Let's stop right here. Okay, Dr. Hanna.
So, this is a really bad tumor, with a poor prognosis. The most common pattern of treatment failure here is distant dissemination. So I don't know what you're trying to ask me, like what is my treatment recommendation?
Yeah, what would you do next?
Yeah. So
I know I would take a vacation and I take this to my car. But
so we have shifted our sort of initial treatment strategy for almost all sinonasal melanomas to neoadjuvant doublet immunotherapy, even in the absence, like this case, of PD-L1 expression. And the reason for that is, we've seen reasonable responses regardless of the PD-L1 status. Obviously, the PD-L1 score, if it's higher, it correlates with a much more predictable response. And I have to sort of put an asterisk on this recommendation that it's not really data driven by anything in the literature that we know of right now, but we are extrapolating from various sources, in the behavior of both cutaneous and mucosal melanomas in the adjuvant setting, and applying it to the neoadjuvant setting, which is, a far cry from an established sort of way of doing things using phase 3 trials, or at least phase 2 trials. Perfect. But the rationale for it really is twofold. One, systemic failure is number one cause of death. And then two, this is borderline resectable. I mean, I have to say that it is not unresectable, but I don't think that's the issue threatening her here. So I would start with that. I would start with neoadjuvant immunotherapy.
Dr. Price, patients somehow find you. What would you recommend?
Well, my recommendations are all with the caveat that I haven't seen a melanoma patient since fellowship, which is much farther away than I like to remember. But I think I can pinch hit. I agree the extent of the disease, and with, the highly effective effectiveness of immunotherapy for melanoma. I agree with Dr. Hanna. I mean, PD-L1 is an imperfect biomarker. And so I think it's at the very least worth a trial of nivolumab, ipilimumab, see if they respond. If they have a really nice response, that is going to predict for a much, better outcome, longer survival, and also help with that distant disease issue. I still think local control will be an issue for this person, unless they have a, complete response
Sure.
or something like that. So, I mean, if they have a good response and, they're not failing distantly, I think it would be reasonable to think about consolidating in some capacity for local control.
So this is mucosal melanoma. What's the I mean, the evidence for cutaneous melanoma and PD-L1 inhibitors are pretty strong, but what about mucosal? How much evidence do we have?
I'm not aware specifically. I mean, most of the data is extrapolated from cutaneous, for mucosal.
Okay. Dr. Lee?
There's plenty of data. Well, not plenty, but there is emerging, I have to rephrase that. There is emerging and pretty convincing data for the metastatic setting for mucosal and in the adjuvant setting for mucosal, but not for the neoadjuvant setting. So the extrapolation is not just from cutaneous, which is pretty robust, but also for mucosal, both for metastatic disease and in the adjuvant setting. And I'm happy to send for distribution some of this literature.
Fantastic. Dr. Lee?
Yeah, I think what we would do, given that the patient had no distal metastases, and if it's resectable, I think our surgeon would operate. And then I do agree distal metastases is going to be a problem, but I also think local regional is also an issue. But I also know that we're not very effective as well. So we have actually published some, a retrospective study. It's not like, where I can get a high control rate, like 90%, it's just not that. And we still cannot find the predictors or local regional failure. But I still think, I'm not aware of trial that will be given or given immunotherapy upfront, but I don't think that's a bad idea either if it's a borderline resectable case. But I think our surgeon will probably operate first.
Okay. All right, Matt, tell us what you decided.
One just little tidbit here, Babak, if I may. In addition to the data for the metastatic and the adjuvant setting, and just a teaser for the North American Skull-Based Society, we are presenting a multi-institutional retrospective review, 17 institutions across the globe, with a couple of hundred, or I can't remember the ultimate number, but the signal for neoadjuvant therapy was pretty encouraging. Now, it didn't reach statistical significance because of the low numbers of patients who have been treated that way, simply because it's a recent thing. But clearly, there was a trend for a much better outcome for patients receiving ipi-nivo in the neoadjuvant setting.
Fantastic. Thank you. Okay, Matt?
Yeah, so I talked to her a lot about combined PD-L1 and CTLA-4 immunotherapy in the neoadjuvant setting, knowing that we would be mainly extrapolating from, as Dr. Hanna and everybody else has said, either patients who had already had metastatic disease and or patients who had cutaneous melanoma. And the patient was pretty miserable with really bad orbital pain. And so she, given that there's really no data to guide us either way, she wanted her eye out. And when a patient is telling me to take their eye out, I usually listen, just because usually I'm doing everything I can to save it. And so in this case, I felt like we could do a reasonable job surgically and clear all of the margins with a craniofacial resection and orbital exoneration, and then just treat her with adjuvant therapy, knowing perfectly well that she's most likely to fail distantly.
Okay.
So that's what we did. This is a different patient, but I just wanted to show some videos of a similar approach. This is for a different tumor, but it's kind of a similar photo of someone who is getting an orbital exoneration maxillectomy. So that's with the specimen removed, orbits out, superstructure maxillectomy. And then in this particular patient, we didn't do the dural resection, but obviously in the melanoma patient, we clearly took out the dura. We did reconstruction with I took some fascia lata off of the thigh and used that as a dural reconstruction. And then my reconstructive surgeons did an ALT to close the surgical site. And this is the post-op scan. There's a big honking flap in there.
So obviously you went from both the craniotomy
all from below.
and the transfacial. What's that?
I did it all from below. So we
All
drilled,
from below. Okay.
yeah. So we were able to, once we took the specimen out, So it wasn't technically on block. Then we were able to drill out the rest of the skull base and resect the dura and send frozen sections circumferentially on the dura. All of our mucosal and dural margins came back negative. Obviously, we didn't take a margin on the brain itself, but everything otherwise came back clear. So yeah, this was our final pathology. Clearly, there was dural positivity, but the margins on that dura were negative.
Okay.
And so I have a couple questions for everybody at this point. She then obviously got adjuvant radiation therapy. And I was just wondering, did people fractionate that any differently than they would for squame? Or do they
Adjuvant alone or combined with an agent? Did you try immunotherapy at all?
No,
post-op?
my medical oncologists who are, given it's mostly cutaneous, but there's a whole melanoma group here specifically. Given that there was no cervical or distant disease and all of the markers were negative, they wanted to save immunotherapy for the inevitable because it's gonna pop up somewhere.
Okay. Well, let's ask Dr. Lee first. What would be
Yeah.
your recommended post-op
Yeah,
adjuvant?
it's a great question. I think some people do fractionate. In my mind, as stated earlier, these patients fail distantly. I don't want them to spend any extra day in my department as more than they need to. So I like the MD Anderson way, and I extrapolated from their cutaneous experience. I can't name published on 6th grade times 5. So I've been doing that, and then 5 times 6 or 6 times 5, and then you're done. You've done, and I don't go after the neck. I just treat where the money is. And then because that would decrease the toxicity. And then, because they fail distantly, and then they go on to whatever systemic therapy, immunotherapy, whatever you want to name.
What's the routine at MD Anderson, Dr. Hannah, for post-op, for a case like this? Obviously had good surgery, reason negative margins are as good as they can be in mucosal melanoma. What would you recommend now, or what would you do?
Well, so, our data suggests that both for cutaneous, that's our local data, both for cutaneous and for mucosal, but I'll restrict it to mucosal here, that the addition of adjuvant radiation improves local control, but does not improve survival. But if you're going to do that kind of surgery for local control, you have to consolidate it and maximize local control. So we would prescribe adjuvant therapy. We've actually started walking away from the hypofractionated regimen a bit from this regimen, because our data also suggested that if you dichotomize patients with less than 56 gray and above 56 gray total dose, 56 gray and above do better with local control. So we've kind of walked away a little bit from that. Still hypofractionation may be at play here, but the total dose is increased.
And do you routinely combine radiotherapy with a targeted agent, with immunotherapy, for chemotherapy, or just radiation post-op?
Just radiation, not routinely. But we do routinely now use, again, I'll stress that, neoadjuvant immunotherapy.
Can I ask a question to panelists? If this patient had undergone neoadjuvant immunotherapy and then had undergone the resection that was performed, and there was a decent pathological response to immunotherapy, I'm looking at you, Catherine, a little bit, would that increase your enthusiasm for adjuvant immunotherapy following surgical resection and radiation?
Great question.
Yeah, I mean, I think if we saw a really good clinical response, pathologic response, that would definitely warrant a discussion about adjuvant immunotherapy.
Okay. Because
by the way, that's another reason, to give it neoadjuvantly, because Matt was saying we reserved it for the ultimate sort of, outcome that we know is coming. And I think 2 courses of ipi-nivo prior to, which is the go-to regimen, prior to her matting out, would tell you whether this is effective or not a priori. And if it is effective, we have put patients on maintenance. And obviously we're collecting all of this data to see if we can develop some sort of backing to this approach.
So Matt, tell us what happened.
she's doing well. She's about 10 months out and is gonna pop. We're gonna see something at some point, but she's 10 months out and is NED. I think we kind of covered how we likely would all go about treating the recurrence of disease, because that's almost certainly going to happen. I appreciate everybody's thoughts. I struggled a lot with this case, mainly because she was really having such significant morbidity from the local site. And so we kind of treated it in the more traditional way. I generally like to see at least something positive come back, even like just some type of either targetable agent or have a reasonably elevated PD-L1 in the setting of where we don't have any real data to support using it without kind of in the setting of everything's negative. I just didn't want to leave her kind of languishing in all that discomfort. So she's doing well for now, but this is
obviously challenging cases, but thank you so much. Okay, we got to move on. It's a fantastic case. I recognize that there are a lot of other experts on the audience. I see you, Dr. Krause and Dr. Weber. I'm so sorry I'm not involving you. Just going to move on. Next is Dr. Ken Bird, our own CDMS member. Ken?
All right, thanks for having me. Let me get my screen shared here. Oh. Sorry, this is a new computer, so I've got to apologize. I'm gonna jump off for 1 minute. I'll be right back.
Okay. So while we are waiting, Dr. Hanna, nowadays when you do open for these kind of cases, I know that the audience are mostly our fellows. Would you, when do you say no? This is open. This is still endoscopic. Where do you some pointers for melanoma, for adenoid cystic, so on and so forth?
Well, I mean, the goal of any surgery is to maximize, surgical resection with margins. So the short answer is you do the approach that achieves that. The limits of an endoscopic resection are known and defined: deep orbital invasion, soft tissue invasion of the face, the anterior table of the frontal sinus, posteriorly to the orbital apex, cavernous sinus, the lateral sphenoid wall where the carotid artery and the optic nerves are, and then significant intracranial disease with the exception of olfactory neuroblastoma, where this still can be done endoscopically. So these are the limits of endoscopic resection, and in these cases, we feel very strongly that an open resection maximizes it. The thing is, a lot of the open craniotomy are supplemented by endoscopic approach, reducing the transfacial incisions still. So you can do a craniotomy for the intracranial disease and still do an endoscopic resection for the intranasal disease.
Got it. All right, Ken, go ahead.
Yeah, sorry about that. I thought I had updated all my settings for all the different platforms, but I guess I missed one. So a 68-year-old female presented to our emergency department with a relatively rapid progression of headache, photophobia, nausea, and left-sided nasal congestion for 5 days. She had admitted some intermittent epistaxis for a couple of months, but no other really significant parts of her history of present illness. Past medical history significant for hepatitis C, hypertension, COPD, and she was severely claustrophobic, which comes up in a minute. And she was a former smoker, but had quit 15 years prior, employed as a prison guard. On physical exam, she had really nothing all that obvious on initial evaluation in the ED. A normal cranial nerve exam and the rest of her neurologic exam being normal. So the ED appropriately ordered head imaging to rule out intracranial hemorrhage versus a mass. Also consulted neurosurgery to evaluate for meningitis. The CT, they did not note any hemorrhage or sign of stroke, but they did note there was a mass in the posterior nasal cavity and sphenoid sinus with erosion of the skull base. So they did consult the ENT service and neurosurgery. Our residents performed a bedside nasal endoscopy that demonstrated a left-sided nasal mass, And again, the patient was very severely claustrophobic, so the hospital service actually admitted her to facilitate her workup, not necessarily at our behest, because this could have been done as an outpatient, but I think more with the pushing of the ED. So we've got a few images here, axial non-contrasted images that show this ill-defined mass with erosion of the posterior ethmoids and filling of the sphenoid sinuses.
Okay.
And here we see on the coronal contrasted MRI that there is a peripherally enhancing mass centered in the left nasal cavity with some intracranial extension posteriorly, as well as involvement in the sphenoid sinus. And what you may or may not be able to see here is that it does approximate the internal carotid arteries on both sides.
So could you see the epicenter of the tumor? Is it this sphenoid sinus or?
It appears to be involving both, sort of in the sphenoethmoidal recess, but probably really kind of based more in the anterior sphenoid sinus.
Okay. And did you have a biopsy yet?
Yeah, so I guess I heard Matt's process. I was just going to throw it up. Do people routinely, our experts or Dr. Hanna or Baba, do you routinely biopsy these in the office or at the bedside or in the operating room?
I'll go first because, I kind of eyeball tested it. Like you look at it and it's like, yeah, maybe doable, maybe not. I have done this. Once we did a biopsy the hemangioperistoma in the office. That was not, that was quite an ordeal. But usually, yes, the answer is we usually do these unless it's really some weird. But you can never argue with caution. And in your patient, looked like they already intubated her anyway. So I think that would be the time to do it. What would you do, Dr. Hanna, and the Anderson?
So controversy, aside, I have not biopsied the nasal mass in the office in the last 15 years. I always take them to the operating room for a variety of reasons. One is a lot of these sinonasal masses, they really need an adequate biopsy. What you don't want is a superficial biopsy. You don't have enough to establish the diagnosis and such. The second really is just the control. Any nasal biopsy will produce some bleeding. The amount of bleeding varies according to the tumor, but olfactory neuroblastomas are very vascular. Melanomas are very vascular. You unfortunately biopsy the hemangioperistoma. And I think what happens with the post-biopsy bleeding in the office is the patient gets anxious. The family are there. They're watching that rigid scope go through the nose. Their shirt or their bib or whatever is messy. Then they get anxious and their blood pressure goes up and the bleeding increases. You don't have control of the airway. So you don't have a reasonable cautery. The silver nitrate is a good thing for Kesselbach's oozing, but not for a hemorrhaging tumor. So I have not, maybe I'm an extremist that way. I do not biopsy nasal masses in the office.
Good. All right. Fair enough. Okay, let's move on.
Yeah, I've done it both ways, and I've regretted doing it in the office. So she was admitted. It was relatively easy for us to get her on for an operative biopsy. So the mass was noted to arise medial to the left medial turbinate or middle turbinate and extended into the sphenoethmoidal recess and sphenoid sinus. There was no abnormality on the right side. The specimen was sent uneventfully. Really, no bleeding in this case, of course, because we did it in the OR. It was sent for permanent pathology as well as for lymphoma workup. And the slide here is some H&E stain of the tumor. We see that it's a round blue cell tumor with areas of necrosis. The circled areas, courtesy of our pathologist, are mitoses, so there were frequent mitoses, and then there's the square is actually, or the rectangle is a triploidy mitosis, atypical. So it was pan-cytokeratin positive, but generally negative for other markers, including synaptophysin. And so the diagnosis was sinonasal undifferentiated.
So we happen to have someone who recently wrote a very famous paper on SNUC.
So we proceeded with systemic workup. She had a hypermetabolic primary with an SUV of just over 9, had some non-specific lymph nodes on both sides that were sub-centimeter. There was one on the right, there was also one on the left that was a little cooler, but no sign of distant metastases. So
just tell us a little bit more about that carotid involvement. How real was that on the MRI when you reviewed the?
Well, there was not any signal abnormality in the carotid, so it was, it was abutting the carotid, but I think the only way we would know if, and if I recall, there was some bone erosion on both sides, but no, no frank luminal abnormality or even deformity of the carotid artery. So, whether it was just remodeling and external compression like you might see in an inverted papilloma, versus invasion and contact, it was obviously that's one thing that I think you don't find out until you operate, at least in my experience.
Sure. Dr. Hanna, what should we do? Debate a Ketchum operation?
Not at all. The first thing I would say is that I would confirm the diagnosis with an expert pathologist, which I'm sure has taken place here. But I alert you to a different paper that we published, other than the one that you are referring to, looking at the misdiagnosis rate of sinonasal malignancy on initial review. And for all comers in sinonasal malignancy, we distinguish between major discrepancy and minor discrepancy. Major discrepancy being a completely different diagnosis, minor discrepancy being the grade or the subvariant. And major discrepancy for all comers was somewhere between 25 to 30%. That's 1 in 3 or 1 in 4 patients. But if we just looked at SNUC diagnosis, it was 60%. That means 2 out of 3 patients coming from the outside world with a piece of paper that says, I have SNUC, have actually something else. So cytokeratin positive makes it a carcinoma. Synaptophysin in chromogranin negative, it makes it not well differentiated neuroendocrine lineage. So it's a good candidate for SNUC, but I would like to see a better immunoprofile to sort of look for some of the other variants, the SMARC deficient carcinoma, the NUT carcinoma, and these would have some bearing on what I would recommend next. Yeah. However, let's assume that this is indeed a bona fide SNUC. I think what you were referring to is our experience with neoadjuvant chemotherapy for SNUC patients. And I would do that even if the carotid artery is not involved, clearly. Our neoadjuvant therapy usually consists of 2 cycles of cisplatin etoposide with assessment after 2 cycles, both endoscopically and with imaging, and then deciding local therapy based on response.
Okay, so Catherine, what's your routine at Mayo?
I'd say we don't have a routine in terms of, treating every SNUC that comes in exactly the same way. Of course, location, extent, and everything has to do with it. I think for this case with the intracranial extension, we would definitely start off with chemotherapy. And, I would say most of the time we start off with induction chemotherapy and go from there, as Dr. Hannan mentioned. Occasionally you come across, more confined SNUCs, in which case, we'll often operate on those up front and then do adjuvant therapy afterwards. I think regardless of the order, this is true for SNUC and for many of the, sinus cancers that, oftentimes they require trimodality therapy at the end of the day. And there's, retrospective data showing that trimodality therapy improves outcomes. So, but I agree, I think these are generally chemotherapy sensitive. So starting off with chemotherapy helps. Both in terms of alleviating symptoms quickly and then helping to determine what your local therapy will be.
So quick question for you and Dr. Hanna. For the SNUC cases, would you send for Foundation 1 or genetic expanded panel? And would you care even to look at the PD-L1? And what's the role of immuno at this point for these?
I wouldn't necessarily do any of those things up front in a situation like this. I would, because again, they're pretty reliably responsive to chemotherapy, so I would do that. We may get those things for the future recurrence that has a high chance of happening. But I wouldn't say that that would help us with what we do immediately.
Very good. Dr. Hannah, I assume you do the same?
I agree. We don't do that routinely, but the only thing I would disagree with is we do have a very systematic way of treating all SNUCs. We don't vary our approach based on location or size or site or T stage. And the rationale for that, and again, that's just based on our own data. And, because it's so, as Dr. Price correctly mentioned, because they are so responsive to chemotherapy, and because we have genomic data that looks at that as very similar to small cell lung cancer, we don't think that surgery up front is the right answer, even for the smaller tumors. From a biology standpoint, you don't have thoracic surgeons taking out small cell lung cancer if they're small, no pun intended. But, this is a chemosensitive tumor. It's a highly metastasizing tumor. And what we've shown is that the response to chemotherapy directs the other two modality. We all agree that a trimodality therapy is needed. What is the optimal sequence of that trimodality therapy is the real question. And again, we've shown that the neoadjuvant chemotherapy tends to select for the most optimal local therapy.
So Dr. Lee, would you, at this point, nowadays, you prefer neoadjuvant chemo alone versus concurrent? Or it's not?
I think we know EHAP's data, but I have to say we kind of practice sort of like what Catherine said, when it's very small, our surgeon will take it out and then we'll follow by adjuvant chemo radiation. I do think that these are sensitive disease, and EHAP is right. In small cell lung cancer, you don't start with surgery, but then I don't even think they even think about surgery, right, in those cases. So that's a little bit different in the head neck region. We would do induction if it's very advanced like this case. In fact, I saw someone just like this case this week on Monday. We would start with induction, followed by Dr. Cohen will come in and look at it endoscopically. Do we need surgery or not? And followed by chemo radiation. Actually, my question for EHAP is, it seems like from your data, some people, you would not even recommend surgery after the neoadjuvant chemo, right? You will go straight to chemo radiation. And that's always a puzzling question for us. We often talk about, should we go to surgery? Should we not? And we think about it, and then we think about your paper, and we want to think what you think.
Well, thanks, Nancy. No, you're right. You're absolutely right. If they have a major response to induction chemotherapy, and that's defined as at least a partial response, which is 50% reduction or more, which happens in about 2/3 of patients, I have to say. We then looked at those who go directly to concurrent chemoradiation versus get surgery, then postoperative chemoradiation. And the group that goes to concurrent chemoradiation without the surgery in the middle does better than the group that gets surgery, then concurrent chemoradiation. And mind you, both were responsive to induction. And we have some theories about what that is. And in short, we think that response to chemotherapy tells you the biology about radiation responsiveness, and putting a surgery in the middle delays that by about 6 to 8 weeks.
Yeah.
And also the definitive dose of radiation that would be given if surgery was not done is reduced to a postoperative dose if surgery was done, which basically reduces the overall effectiveness of radiation as a tool in the management.
Yeah, we have 1 minute. So Ken, this is the case I thought less controversial, became more controversial. Okay.
Yeah, and I'd also add, to Dr. Hannah's comments that our pathology panel was much more extensive than what I presented. I put 2 slides in really just for the fellows education. So our pathologist is experienced and did feel pretty confident in calling it a SNUG, but that's a good point. So in this case, we talked about the MD Anderson protocol of the induction trial. In talking at our tumor board with our medical and radiation oncologists, we didn't feel that this was a surgical case really at all. And so they felt more comfortable proceeding with definitive chemoradiation. So she got 60.4 grade of the primary, 50 to the next, with 3 doses of cisplatin. She had some residual activity on her PET CT at 12 weeks. Went for a biopsy, which I did, was a significant biopsy of multiple sites. It did not appear to be consistent with the same consistency of the primary tumor. And so it was all radiation effect and scar tissue, no viable tumor. And so we've been following her with serial imaging since then. I've not seen any progression, and her diffusion signal is normalized.
So this, we could assume that this would have been a patient that if you had started with induction chemo, would have responded. And then you, as Dr. Hanna said, you consolidate with just chemo RT, no surgery.
Yeah, that's my thinking, is that that she must have favorable response characteristics.
There's a question in the chat about SMART-B1 INI, which I think is deficiency for SNUC. I guess one of the questions for the panel is, in general, are there any pre-treatment biomarkers that you look at prior to decision of therapy to change or deviate away from induction chemotherapy followed by risk-adapted, definitive therapy?
Dr. Hanna?
Well, this SMARC deficient, INI deficient tumors, we actually think more of them as squames that are bad squames rather than SNUC. I mean, people think of them as a variant of SNUC, but it really is more along the squamous cell lineage. And in those cases, the chemotherapy choice for induction is a little different. It would probably be along more the squamous sort of drugs instead of the neuroendocrine drugs. The surgical component is considered a little bit more than in the SNUC. So if they have sort of a little bit of a response, but not as robust, we think, as long as they're resectable, we think surgery has a much more prominent role than a pure SNUC. So these are the differences. The induction would probably be a little different, and moving to surgery has a lower threshold.
Okay, so it's 802 fantastic cases, an amazing conversation. I cannot finish this without asking Dr. Lee, would you do proton for these nowadays or not?
I forget how old the patient is, but
64, 65.
Yeah, I mean, I think when you can do both. The truth is you can do both, but I do think that proton has the advantage in the skull base that's pretty well known to protect more normal tissue. And so I think we sometimes leave it up to the patient. We are seeing more and more people coming to us requesting proton, even in cases we don't think proton is absolutely mandatory, they were requested. So I don't see anything wrong with proton. The reason I sometimes think about, age is, I think younger patient, like the first 38-year-old lady, I just feel like, I think of the young and I think about adenoid cystic living long time. And, the truth is, follow these patients 20 years later, you're going to have all the cranial neuropathies and problems, and then temporal lobe necrosis that we never used to think about. We don't think about it because we weren't imaging them aggressively. But, I always think about long-term and younger patients, I will recommend proton more.
Perfect. Well, thank you. This concludes our tumor boards for February. This was a fantastic panel. Thank you all for presenting. Dr. Megan Turner, Dr. Matthew Geltweiler, and Dr. Ken Bird, and our expert panel, Dr. Catherine Price, Dr. Nancy Lee, and Dr. Ehab Hanna. I would like to give a shout out to all the audience as well. I saw Dr. Shaw, Dr. Krause, Dr. Witterick, Dr. Weber. Thanks for participating. Our next session is on March 2nd on difficult parathyroids. Please join us. I have a very good case for you guys, so I'm not going to tell you. But thanks again. That was a fantastic panel. Have a good night. Stay safe.
Thank you, everyone. Thank you, Dr. Giddy.